Okay, so this is the fifth session looking at this issue of iatrogenic interventions in schools. This is a uh, topic that is very interesting to me, and it's kind of surprising how little we know about these issues I'm about to get into. I say that meaning that we actually know a lot in terms of what we say to each other and how we perceive things within schools, but what we actually say in the research literature around these things is very minimal. And we were very proud when we did our book that we actually got to focus a chapter on this topic because of the need for us to, I think, be critical of all interventions, whether we're the ones creating them or the ones that are researching them for a client. And one of the things that we know that I think is really important for us to live with is that our field, and by field I mean social work, but also mental health more broadly, psychology, psychoanalysis, psychology, is been guilty of creating a range of things that either haven't been fully tested or when tested did not necessarily work or actually made things worse for kids and other people. And these things, as I start to lay some of these out, you'll recognize from the chapter that we have. Some of these are in there, some are not. I put these all together though, and we can go through them a little detail in a second, because what they speak to is the way that authority-based practice and the way that the field can kind of tell itself over and over that what we do works can be very dangerous for our field. Sometimes directly harming people, but also in some ways creating fatigue around the use of interventions and the belief in interventions being effective, and also in some ways making clients feel like they're not doing things right, or that they could be better if they only did the intervention as the therapist or clinician told them about it. So the first one that you might recognize up there, that probably all of us on this module could probably tick off without much effort, is the business about the stage theory of grieving. Kubler-Ross was a great influence in the field of psychology and psychiatry. The idea of grief as a stage process is something she was instrumental in bringing to our consciousness. Unfortunately, the research she originally did was about people who were actually dying, not the people who were grieving for them. And that was in some ways a very limited set of evidence because she did interviews with people who were dying or about to die, didn't have much chance to do follow-ups with them. And again, this was at a time in the 60s where there really wasn't a lot of thinking and attention paid to this topic at all in the fields of mental health. And so in that sense, she did a great service. But she also did not create a theory that was meant to, again, be for the living. Later on, it was kind of adapted to that. So, and again, going back to adaptations and thinking about adaptations, those things are worthwhile. The problem is that now that people have, over the last 20 years or so, begun to test this theory and to try to assess whether this theory, in fact, follows the sequence that we all know about when we think about it, they have found that to not always be the case. And if anything, they've found that some people don't have the stages in their grieving at all, or certain people go through different stages in different order. And why does it matter? In this case, it matters because people are, I think, in a lot of ways, at this point, not even needing a clinician to think about themselves in stages of acceptance or bargaining or denial. The problem is that we're beginning to see some evidence of people worrying about grieving correctly or feeling like they've been told that they're not grieving because they're not doing things using the stage theory. Going down a little bit further on the slide to this idea of individual grief therapy, this is in the chapter. Thinking about this as a way to unnecessarily pathologize kids having grief reactions. Again, not directly connected to the Kubler-Ross work, but again, not taking into account a range of ways that people might experience grief can be harmful. It can make people who are going through a tough time feel even worse, and it certainly doesn't advance an evidence-informed way of thinking. Other ones you see up there that are in the chapters, and we'll talk more about what the chapter did to organize them. Certainly zero tolerance, abstinence-only education, which is a hot-button issue that, again, has a lot of political resonance for a lot of people. Scared straight programs, again, another thing that politicians like to tout, that they're going to send kids to boot camps and going to make them have to, uh, you know, fly right and ship up or shape out, shape up or ship out, I guess is the saying. DARE is another one with a lot of political support. Grade retention has at times, you know, we gotta be tough on these kids, higher standards, keep them in school in the grade they're in. Um, Grouping aggressive adolescents, that's a very kind of controversial and problematic thing to do. A lot of us that are in middle school or high school know how easy it is sometimes to put a bunch of kids together who already have conduct issues, and we find that maybe they get better at those conduct issues as opposed to learning strategies to not get so angry. Um, I tease those out because those are all specifically in this chapter. There are others that aren't. The rainbows we'll get to. Rainbows for All Children is actually All God's Children is a program that was designed to help kids coping with divorce of their parents and or a loss of a parent or a sibling. Um, we'll get to that in the section we do when we talk about coping with their parents' divorce and the problematic lack of evidence for rainbows, even though it's the most dominant program arguably in the country. Certainly, this last one, this idea that we had an explanation for a while where the way that mothers communicated with their children could create this double bind communication. You might remember this way back when, that was somehow related to causing schizophrenia or autism. It sounds a little bizarre and far-fetched now, but this was something that was active, and you know, as a way of thinking, even during some of the 50s and 60s, and certainly think of all the harm that that caused. Families thinking that they somehow caused their kids to have these mental health issues. Another one up there, critical incident stress debriefing, which again is not focused on in the book, but is part of another book I actually did, The Domains and Demands of School Social Work Practice. Historically, there's been a lot of interest in doing things for people who've experienced a traumatic event. One of the most popular versions was this technique where you would, it means a lot of things, but essentially there's an idea about some group catharsis, some gathering of people together to recount or to in some ways mark the incident or traumatic event. Recent scholarship over the last 10 years, though, has raised questions about whether that's actually helpful and if in fact it may actually re-traumatize people. And just, you know, it just so happens today there was a traumatic event that had happened over the weekend, not to my family directly, but to the school district in which my kids go to. And I'm happy to say, as far as I can tell, that the way that the school is approaching that incident of a key adult that died is to not employ some of those critical incident stress techniques, but instead to look more about a triage process and getting kids the help they need at the pace they have, and honestly, probably letting kids have normal grief reactions as well. Okay, so let's talk about the ones that I quickly went through, because those things are the ones that I think really cut to the quick of this chapter and also raise some pretty concerning issues for me about what's in schools today. So, PhDs, this comes from a line of scholarship by a guy named Lowenfield and his colleagues, thinking about potentially harmful treatments and locating them at a couple levels. The first level being that it's probably harmful for some school clients, so it's pretty likely that the evidence that's available indicates a risk of harm, that it's going to make client outcomes worse or school situations worse. The second level would be that it's possibly harmful. So it may not necessarily be harmful for everyone, but it could be, and it may be a default neutral. Like there may be a lot of energy and effort put into something that doesn't really make much difference at all. These things are again part of the fabric, and arguably in some ways more common than some of the other things we're going to study in this class this semester. And that is really what I want us to park on for a little bit. When you look at under the first level, you look at that business of grouping aggressive youth, this idea of grade retention, looking at doing violence prevention, but not getting a baseline of where kids are at or where they're at in relation to their social skills. The idea of substance abuse prevention, specifically around DARE, and grief therapy and the critical incident debriefing. These things have been shown through a range of high-quality, rigorous designs, QEDs, RCTs, a systematic review, a meta-analysis, to actually potentially make kids harmful or be harmful to kids, make kids more likely to experience the problems that the intervention is seeking to address. Looking at the second level, ones that do potentially harm are abstinence education and zero tolerance. Um, Obviously, both of those have really been subjects of controversy. People have strong feelings about these that aren't necessarily evidentiary feelings. These are feelings based on values, based on what they experience as children, what they think that their kids in the school district should do. The problem with zero tolerance, I think those of us who've been in schools a while know, it's often applied in a disproportionate way to kids of color or kids of lower socioeconomic background or kids in special ed. The idea of being kicked out of school for a first offense of something like bringing a weapon to school or bringing drugs or getting in a fight or any of the other things that schools feel compelled to do zero tolerance on not only doesn't necessarily keep the school safer, which is partly what the thinking is, but of doing it, but also that it actually affects the academic achievement of that youth as well as even the overall academic achievement of the school. Because schools that want to do zero tolerance want to do it in the name of safety, but they don't necessarily create safer schools, and they also often create more stress around these issues. Abstinence education, the idea that there is a way to um, emphasize abstinence is certainly not, to use a value term myself, a bad thing. I think there's a lot of evidence to say that abstinence is a good message to give young people. However, when not paired with information about birth control and other issues of sexual health, it can be potentially inaccurate or misleading. And it's actually been shown both in this one and then the DARE substance abuse education that when not done accurately and with the right kind of level of intensity and tone, some of these abstinence-only curriculum and substance abuse prevention curriculums can actually encourage kids to do drugs or try unsafe sex before marriage because the way it's explained doesn't really convey accurately some of the risks and issues. So kids begin to discount everything that they're hearing from the topic. Again, these are not hard and fast. The science is still expanding and growing. There's a lot of debate in the literature around the issues of things like controversy or grouping aggressive youth. Certainly, zero tolerance and abstinence education are still very much hot button issues that people can get very exercised about. What I mean by implications for practice and why I think this is so important for us to take seriously is when you look at these things, and I'll say something about social stories in a minute before we end this one, it's clear that these are things that have a very high uptake rate in schools, that many schools are employing many of these interventions, sometimes for many years, to the point where some of you listening here to this may identify yourself as having experienced some of these things in grade school or middle school or high school. That speaks to, I think, a concern that I have about being evidence informed and thinking of iatrogenic interventions and not just looking at interventions that help, because the nature of these interventions being in schools for so long and largely unquestioned, or at least if questioned, not questioned, using some of the tactics and ideas from this course that are being used around evidence informed practice, they tend to linger. They tend to, if anything, become assumed to be effective. It may go without saying, but it's worth saying that a lot of these programs don't collect data on whether they work or not, or like the Rainbows program, as you'll see when you read that chapter, they kind of act as though they have data for their program, but don't really provide it in a peer-reviewed, transparent way. The data on DARE was so bad for so long that there was accusations that they were keeping it from people and discouraging researchers from doing research on it. Once some of this data came out and research came out that showed that DARE may be harmful, to their credit, they've retooled a lot of what DARE is, and there's now a more mixed profile of what DARE does. But what I want to leave you with is that these things are very much in kind of the fabric of American schools, and others that aren't on this list. There are others that you could probably think of. And the key part is not to just dismiss them or to grow cynical about them, but to say, if these things are in my school, or these are things our school is considering adopting, how can I marshal the best available evidence to discuss that and to possibly argue against it? And definitely, I start with this after the intro lectures because I want you to think of your school, think of the things that are assumed to just be effective or to be fine to do, and think about what you would maybe want to do to raise concerns about that. And again, it's not to just turn it into some sort of personality disagreement where you say, "Well, I like it," and they say, "Well, you know." Or you say, "I don't like it," and they say, "Well, we do, and we've been doing this a long time, and who are you, school mental health person, to tell us that?" To really come at it from an evidence-informed lens and to say, "Did you know that zero tolerance policies actually have been shown to make schools less safe? Do you know that when scared straight programs are implemented either in schools or after school programs, that those kids actually have a stronger likelihood of getting involved with juvenile justice? Do you know that grade retention doesn't actually impact the academic achievement and increase it the way that that is hoped for?" These are the sorts of things that can be evidence-informed conversations.